From Cradle to Grave. This is chapter 8 in your text. Interesting chapter, kind of a long one, but we'll get through it. Don't worry, we'll get through it. Psychoactive drugs from birth to death. A fetus is exposed to heroin through the umbilical cord after an addicted mother shoots up. This, of course, happened in my own family. 14-year-old is offered MDMA at a party to get rolling. Rolling, rolling, rolling. A college student troubled by bulimia makes herself throw up 5 times a week. A young mother with 3 children hides in her room to smoke crack. A 28-year-old IV methamphetamine user infects his girlfriend with HIV when having sex after using a contaminated needle. In one office, one worker is taking Klonopin to deal with the anxiety, while another takes Prozac to combat depression. A mother with grown children battles boredom and the empty nest syndrome by compulsively playing poker machines. A 50-year-old salesman on the road smokes and drinks to cope with loneliness. A 74-year-old with arthritis borrows hydrocodone from a neighbor to relieve the pain. Prevention and treatment throughout life. Encourage the pregnant mothers to attend prenatal care programs to teach them how drugs affect their fetuses. Greater public scrutiny of parties, limiting the use of club drugs. Offering counseling on eating disorders in high schools and colleges. Using outreach workers to encourage drug users to practice safe sex and use clean needles to prevent the transmission of HIV and hepatitis C while attempting to bring them into treatment. Doing an intervention to get a heavy drinking sales representative into an employee assistance program. Holding seminars to enlighten senior citizens about drug cross reactions. Each society has to decide how they want to attempt to prevent self-destructive drug use. Are they trying to prevent any use of psychoactive substances? Are they trying to ban just illicit drug use? Are they trying to limit the damage caused by use, abuse, and addiction? The U.S. and most other countries use a 3-tier approach to fight the destructive effects of psychoactive substances. Primary prevention is a program to teach the skills to help the individual resist drug use. Secondary prevention, stopping the behavior wherever and whenever it starts. And then tertiary prevention, putting people through treatment and restoring them to health. So we try to stop it before it happens. If it does happen, we try to stop it when it occurs. And if it does happen, we try to get them into treatment to restore people to health. Governments work on prevention by reducing the supply of drugs through interdiction of drug supply, legislating against use, and legal penalties for possession, use, and distribution. They also reduce the demand by treatment of drug dependency and prevention through education, emotional development, moral growth, and individual and community activities. They try to reduce the harm that can be done to the community by promoting temperance, instituting needle exchange programs, supporting drug substitution programs, lessen the effect of alcohol, for example, by supporting designated drivers, and decriminalizing drug use. Worldwide, the most widely used and successful programs have been supply reduction and temperance methods. Historically, in the United States, drinking and smuggling of spirits became part of the American fabric. It was easier for farmers on the frontier to ship their corn produce in the form of corn liquor than as grain. However, with the influx of evangelical influences, the Methodist and Baptist movements, temperance became more acceptable as an alternative to heavy drinking and drunkenness. Such behavior came to be seen as destructive, sinful, and immoral. An effort was made to get drinkers to switch from hard spirits to weaker beer, wine, and hard cider. Dealing with the problem of alcohol consumption has been a continuing problem in the United States, fluctuating between moderation and forced abstinence, prohibition. As a country, use and the responsive movements have waxed and waned in 70-year cycles since the beginning of our history. In 1780, Dr. Benjamin Rush tried to legislate control over distilled spirits. In 1850, temperance movements supported replacing distilled spirits with more benign drinks. In 1920, prohibition of alcohol was passed. In 1990, legal drinking age was raised to 21 nationwide. So one of the arguments is that prohibition didn't work, and so the question is, did the 18th Amendment actually work? Alcoholic psychosis admissions to state hospitals in New York and Massachusetts was cut nearly in half. Deaths due to cirrhosis of the liver were cut in half during Prohibition. There was less crime in general. There was less domestic violence. Even after Prohibition stopped, drinking levels remained low and didn't return to pre-Prohibition levels until the 1950s. Medical problems increased from unregulated manufacturing of alcohol, but the level never approached the medical problems that the nation experienced from the alcohol. Some argue that Prohibition brought organized crime to the United States, but in reality, organized crime has been a part of the American underworld fabric since long before the 1920s. Unfortunately, one problem with Prohibition was that because banning alcohol was touted as a cure for all of society's ills, treatment for alcohol addiction was cut. Some people claim that Prohibition was repealed because of the universal condemnation of the ban. But the real reason for its repeal was due to the need for tax revenues for its manufacture and use during the Great Depression. Pressure from the wets and fatigue dealing with continued argument did not hurt either. In 1962, before the Civil Rights Movement hit its stride and before the Vietnam War, only 2% of the American public used illicit drugs. However, with the aforementioned social movements and an air of social disobedience streaking through the youth of the 60s and 70s, 31% of the population was using illicit drugs. During this time, knowledge-based programs were started to teach about pharmacological effects, causes of addiction, health effects of drug use, legal penalties. There is no evidence that information alone causes changes in behavior, sadly. So knowledge doesn't help. Skill building and resiliency programs, as more research was being done, it was discovered that there were obvious psychological and developmental factors that predisposed select individuals to drug use. Programs aimed at these individuals targeted social skills that might protect the individual from experimentation. Skills that addressed risk factors that might lead to drug abuse included general competency building, training in self-esteem, socially acceptable behavior, decision-making, self-assertion, problem-solving, vocational skills. Coping or resistance skills, developing self-reliance, confidence, and inner resources. Reinforcing protective factors and resiliency build on natural strengths that people already have available: their optimism, their empathy, their insight, intellectual competence, their self-esteem, direction or purpose in life, determination, supportive friends and family, opportunities to belong to meaningful groups. Skill building and resiliency programs address and reverse risk factors. Risk factors associated with future substance use disorders should be examined, with the focus being to seek strategies to minimize their development. Early aggressive oppositional disorder, poverty, lack of parental supervision, dysfunctional drug-abusing peers, and that's what the picture is. Dysfunctional drug-abusing peers. Skill building and resiliency programs support system development, endeavoring to reduce stress for students, which should decrease the need for drugs and alcohol abuse. Changing the environment, one early target for concentration is the social and environmental influences that lead to drug use, family values, peer group values, and practices in schools. This is an attempt to get the entire neighborhood to take responsibility for preventing substance abuse by assessing the needs of the community, coordinating existing services, changing laws and public policy to reduce availability, increase funding for families, school and community prevention, community-wide training, and planning. The public health model for prevention sees addiction as a disease. The user is a genetically predisposed host. The environment contributes to the problem. The drug is introduced, causing the disease. Prevention involves disrupting the relationship between one or more of these factors. The family approach. This approach sees addiction stemming from family dynamics. Families are bolstered through family support, skills training, therapy, parenting programs. This approach focuses on the family rather than the environment. Supply reduction seeks to decrease drug abuse by reducing the availability of drugs and is the responsibility of state and local police departments, the Department of Justice, which includes the FBI, the Bureau of Prisons, the INS, and DEA. DEA is Drug Enforcement Agency, and INS has to do with Immigration and Naturalization Services. The Treasury Department, which includes ATF, Alcohol, Tobacco, and Firearms, the IRS, Internal Revenue Service, and Customs Service. Department of Transportation is also involved in drug interdiction, as is the Department of Defense. The responsible agencies reduce drug supplies by interdicting drug smugglers, manning law enforcement activities at border crossings, limiting the supply of precursor chemicals, disrupting criminal gangs and organized crime, passing more severe laws, increasing community police officers, disrupting money laundering and seizing assets, supporting local and state police in high-volume drug areas, supporting the anti-drug efforts of foreign countries, enacting treaties to work towards supply reduction. Drug laws in the United States have evolved to curtail the supply and use of illicit drugs. Long prison terms and forfeiture of assets have been used to discourage suppliers and manufacturers of drugs. Users are discouraged by facing stiffer and increased jail time. Possession of paraphernalia adds to the length of time spent in jail. Many states, including California, enacted 3 strike laws in the 1980s, which mandated life imprisonment if an individual committed 3 felonies in their lifetime. Since 1980, prison populations have tripled. 55% of the inmates in federal prisons were convicted of drug offenses. If you count felonies committed to support drug habits, the percentage increases to 60 to 80%. Over half the inmates incarcerated admit to using drugs while they committed their offense. The percentage of teenagers is even higher. A great deal of money has been spent on supply reduction. Advocates estimate that it has resulted in a 10 to 15% supply reduction. The severe penalties have resulted in a delayed impulse to use. It has opened up treatment. It has kept people in treatment. Detractors of the policy complain of the minor impact on supply. These individuals support a more demand reduction approach. Demand reduction involves the 3 tiers of prevention: primary, secondary, and tertiary. Primary prevention has to do with utilized by promoting abstinence, help young people refuse drugs, delay the age of first use, encourage healthy non-drug alternatives. The age of first use is strongest predictor of drug or alcohol use. Individuals who experiment before age 12 have a 4 to 5 times likelihood of further drug use. Secondary prevention seeks to halt drug use once it has begun. This tier of prevention adds intervention to the primary strategies of education and skill building. The biggest problem with this program is denial by the user and their concealment of use, making them difficult to identify. Another problem with this tier of prevention is that there is a lag phase between first drug use and physical and emotional problems. The user feels that the educational programs are overstated. Tertiary prevention seeks to provide treatment for the user to restore them to health. Compulsive drug use is addressed through group intervention focusing on detoxification, abstinence, and recovery. Cue extinction therapy that desensitizes the user to people, places, and things that triggers use. Family therapy, group psychotherapy, or residential treatment. Instruction in relapse prevention and life management skills. Psychopharmacological strategies, promotion of healthy lifestyles, development of support and aftercare systems such as 12-step programs. Tertiary programs result in decreased drug use or abstinence in 40 to 50% of the cases. 74% reduction in crime, 2,500,000 people receive treatment nationwide. 21,700,000 people are estimated to need treatment nationwide. So we have about 1/10 of the individuals who need it are getting treatment. Not all programs seek abstinence. Harm reduction programs recognize that recovery is difficult, and many will relapse before they are able to live their lives drug-free. I just read a statistic on relapse. It's between 80 and 95% of people who go through drug treatment will relapse at some point. This technique focuses on minimizing the personal and social problems caused by drugs. Three harm reduction programs, needle exchange programs to reduce the spread of HIV and hepatitis C, bleach distribution programs to reduce the spread of HIV and hepatitis C, and legal drug substitution for illegal drugs. The replacement of heroin with methadone is a good example of the drug exchange program. Harm reduction programs have also proposed some controversial ideas. They accept the fact that people will experiment with drugs and they want to educate them to use drugs responsibly. Decriminalizing or even legalizing illegal drugs is another controversial idea. Treat addicts by reducing their usage to the manageable level rather than seek abstinence. Allow addicts to design their own intervention and treatment programs. Some of the most lucrative advertising on television is advertising for alcoholic beverages. Before 1996, hard liquor was not advertised on television, only beer. The idea from the temperance argument of the 19th century was that replacing hard liquor with beer would reduce drunkenness and the destruction of alcohol. However, more people die from cirrhosis of the liver caused by beer than cirrhosis caused by hard liquor. Damage done by legal drugs cause more damage to the society than illegal drugs. Alcohol, tobacco, and prescription drugs are three legal drugs. Advertising for these drugs brings new users into the fold every year. Facts to remember about prevention: there are no quick fixes. Prevention will never be complete because there will always be new potential users to convince. Prevention campaigns become progressively more difficult in time because they have already reached the easy cells. No single approach has been shown to work consistently. Legalization of marijuana and the medical form of marijuana will make it more and more difficult to control all drugs. When we see depictions of drug addicts in the media, they are often portrayed as weak, bad, stupid, crazy, immoral, poor, and disenfranchised. 1/3 of the homeless have a drug or alcohol problem. This only represents 5% of the addicts in the United States. The truth is that whites are the most likely to have either a drug or alcohol problem. African Americans are just as likely as whites to have a drug problem, but the least likely to have an alcohol problem. Hispanics are the least likely to have a drug problem. People in low-income areas are less likely to receive treatment and more likely to be incarcerated for their drug use. More affluent people are more likely to receive treatment and probation. 53% of the individuals in prison for drug crimes are African American. 26% of those in prison for drug crimes are white. Among the highest paid occupation in the United States, physicians, they are as likely to be addicted as the general population, though they are more likely to be addicted to prescription drugs. Members of Mensa and gifted high school students have high rates of addiction. Members of the clergy have high rates of alcoholism. When I was teaching high school in Springfield, Nebraska, we had I was in charge of the talented and gifted program, and we accumulated all these brilliant children that we had, and of those kids, there were about 15 of them. I took them to a conference, and we listened to seminars on on very important things. This was back in '83. Anyway, so after I was only there for a year, and then I went off to California, and then I came back. When I came back, everybody was talking about all these kids that were, all these brilliant kids. 5 of them had turned into drug addicts. 5 out of the 15. Two of them were brother and sister, and yeah, it was kind of ugly. And there was one suicide. So of the 15 kids, there were only 9 of them that went off to college. Five of them, 5 of them were drug addicts, and one of them had killed himself. While addiction rates fluctuate with attempts to curtail use, over the last 40 years, the age of addicts has declined with the age of first use. Between 1991 and 2005, the number of 8th through 10th graders who used marijuana increased 60%. Juvenile arrestees testing positive for drugs other than alcohol ranged from 48 to 65% in 2005. It is estimated that 18.6% of infants are exposed to alcohol in the womb. 4.5% of fetuses are exposed to cocaine. 17.4% of fetuses are exposed to tobacco. Fetal alcohol syndrome is the third most common birth defect and the leading cause of intellectual disability in the United States. Drug use during pregnancy can create nutritional and obstetrical complications, can cause anemia, sexually transmitted diseases, diabetes, high blood pressure, neurological damage, weakened immune system, poor nutrition, hepatitis C exposure, endocarditis, HIV/AIDS exposure. 80% of the infants born with HIV in the United States were born to mothers who were IV drug users or the partners of men who were IV drug users. Worldwide, the figure is 90%. Unfortunately, the life expectancy of a child born with HIV is only 2 years. With AZT treatment for the pregnant mother, rates of HIV infection drop from 25% to 8%. Pregnant addicts often live chaotic lifestyles that don't afford time or the wherewithal to seek or accept prenatal care or medical intervention. When the addict is an adolescent, the individual is at greater risk and even less likely to seek treatment. Other problems are likely because of her physical, emotional, and behavioral immaturity. Besides the effect of the drug on the fetus, the mother's toxic environment often has deleterious effects on the fetus and the mother: poor nutrition, bloodborne infections, domestic violence, sexually transmitted diseases. Most psychoactive substances readily cross the placental barrier, meaning that the tiny infant is exposed to the same drugs at the same level as the mother. After birth, the drugs will be passed to the baby in the mother's breast milk. Because of the excessive organ and brain development, the 12 weeks in the first trimester is the most critical period in the baby's life. Drugs used during this time period can change the baby both physically and mentally. However, since the brain continues to grow throughout gestation, neurological damage can be done at any juncture during gestation. If heroin or cocaine is used during the last trimester, they might cause premature birth. If the baby is born after the mother has used drugs on a regular basis, the neonatal period will be fraught with intoxication, withdrawal, and eventually developmental or learning delays. And that's what has happened in my own family. If the infant is given concentrated care after birth, they will manage to catch up with their non-drug exposed peers, potentially by toddlerhood. Alcohol is one of the most devastating effects on the fetus of all the drugs. The effects of alcohol have been studied more than any other psychoactive substance because of its prevalence and the general acceptability of the drug. And of course, I told you before, when I was working in Omaha at St. Joseph Hospital, part of the hospital is Boys Town Institute, and they were doing studies on fetal alcohol syndrome. At that time, we weren't exactly sure. All of the information that we have about fetal alcohol syndrome came out of that type of research, and they were on the cusp. They were on the tip of the spear as far as fetal alcohol syndrome research was concerned. So we were exposed to this research while it was actually happening. Fascinating stuff. What else did I want to say? Okay. Oh, my nephew, my great great nephew. I have a great great nephew that was addicted to heroin when he was born. Took him 6 weeks to detox. He has rage issues, and he probably will never ever be able to live a normal life. Mainly, well, his upbringing has been fairly poor because his mother was a heroin addict and she married her supplier. And of course, they can do no wrong because, well, anyway, it's an ugly, ugly situation. When a mother drinks during pregnancy, the possible effects on the fetus are referred to as FASD, fetal alcohol spectrum disorder. The most severe form of FASD is fetal alcohol syndrome. Fetal alcohol syndrome is characterized by physical abnormalities, mental abnormalities, and behavioral abnormalities. I can remember the day the researcher came down to the lab, to our lab, and was talking about his research. And he had brain cells. He had some kind of brain cells. They weren't human brain cells. I think they were mouse brain cells. He said it's the most amazing thing. The alcohol has an affinity for fetal brain cells, for fetal brain tissue. It goes right to it. He said he didn't understand. It was like a magnet. It just drew it, the alcohol to the brain cells. These babies are born to mothers who drank heavily during their pregnancy, physical abnormalities, mental abnormalities, and behavioral abnormalities. Growth of the FAS fetus occurs in the womb, reduced height, reduced weight, reduced head circumference, reduced brain growth, reduced brain size, facial deformities, shortened eyelids, thin upper lip, flattened midface, shallow groove in the upper lip. Heart problems, limb problems, delayed intellectual development, neurological abnormalities, behavioral problems, visual problems, hearing loss, balance, and gait problems. And this is an individual who suffers from FAS. Part of the FASD, fetal alcohol syndrome, fetal alcohol spectrum disorder, are less severe disorders. Alcohol-related neurodevelopmental disorders, ARND, alcohol-related birth defects, ARBD. Worldwide, fetal alcohol syndrome affects as many as 2.9 per 1,000 births. In the United States, the rate is 2 per 1,000 births. Among African Americans, the rate is 6 per 1,000 births. Asians, Hispanics, and whites have rates between 1 to 2 per 1,000 births. American Indians have rates between 10 to 30 per 1,000 births. Now, you may say, well, is that what it is on the Navajo Nation? And the answer is probably not quite that high. The area, the indigenous group that has the highest alcoholism rate is on the northern plains. Montana, Wyoming, North Dakota, Idaho, Washington. In one study of fetal alcohol syndrome adolescents and adults, it was discovered that all of them had been physically and sexually abused, 60% of the abuse occurring before adulthood. The individuals averaged 6 diagnosable mental illnesses. Select ones had 10 or more mental illnesses. Cocaine and amphetamines are used by 558,000 women in the United States every year, with most of them falling into the reproductively viable range. In the 1980s, when cocaine was use was at its peak, it was estimated that 4.5% of all babies born in the United States were exposed to cocaine in the womb. In inner city hospitals where cocaine use was more prevalent, the percentages ranged from 15 to 25%. And I've told you before that I worked at Children's Hospital in the early 80s, and by golly, we saw this on a fairly continuous basis, and it was not a pretty sight. A lot of these babies didn't survive. A lot of them had physical abnormalities that were not survivable. It was not a happy time. And the other interesting thing about the situation was that the women that were doing the drugs at this time, of course, cocaine was the all the wealthy people were doing it. So they were the ones that were having babies with all the problems. And it was not a happy time. And then, of course, crack hit the streets after cocaine wasn't nearly as popular. All of a sudden, we had all these crackheads. Oh, what a lovely time that was. When was it? 82 to 87. That's when I was working at Children's Hospital in Omaha. The effects of stimulants, increased heart rate, constricted blood vessels, affects not only the mother, but the unborn fetus. For the fetus, the constricted blood vessels results in restricted blood flow, restricted nutrients, of course, and restricted oxygen. This retards development. For habitual users, the effects can be more pronounced. In extreme cases, the increased blood pressure may cause the placenta to separate from the uterine wall, resulting in spontaneous abortion. Excessive use of stimulants can raise the fetus's blood pressure, causing a stroke. Using in the third trimester can result in extreme activity in the fetus, causing the uterine contractions and premature labor. Withdrawal for the fetus involves several weeks of extreme agitation, increased respiration, hyperactivity, possible seizure. Effects last into the child's second year with lifelong disability rates of 33%. Oh, that's not so high, 1 out of every 3. Since opioid use tends to be more continuous than the binge use of stimulants, the effects are greater. Problems include severe infections from IV drug use for the mother, fetal growth retardation, miscarriage, stillbirth, separation of the placenta from the uterus. Babies born to heroin addicts are often premature, small, and weaker. These infants have abnormal sleep patterns that leads to a 600% increase in SIDS deaths. 600%, 6 times what we see normally. 60 to 80% of babies born to opioid addicted mothers go through withdrawals 2 to 3 days after they are born. And this is what my great nephew did. Hyperactivity, incessant high-pitched crying. It sounds like a cat caught in the garage door. Increased muscle tone, irregular sleep patterns, increased respiration, poor suckling, failure to thrive, irritability, sweating, tremors, diarrhea, sneezing, vomiting, and very often death. Marijuana is used by 5 to 17% of pregnant women during their pregnancy. A longitudinal study of marijuana exposed fetuses in Canada showed that poor short-term memory and verbal reasoning at age 3, continued poor memory through childhood, lowered verbal performance from childhood through childhood, impulsive hyperactive behavior, but they're not ADHD. Well, we can't treat it with stimulants because, well, they may get addicted. Conduct disorder problems, distractibility, poor executive function. The problem with marijuana is the same as the problem with any other drug smoked. Decreased oxygen, irritated alveoli and bronchi in the lungs, decreased weight and withdrawals, abnormal responses to visual stimuli, increased tremulousness, easily startled, high-pitched cry. Drug fetal effects, category A, vitamins other than vitamin A, no fetal risks, so we're okay with vitamins. Category B, acetaminophen and ibuprofen, no fetal risks, so you're okay taking acetaminophen and ibuprofen if you're pregnant. Category C, most medications, no fetal risks, so most medications you're okay. Category D, anti-seizure, benzodiazepines, and tetracycline. Tetracycline is a antibiotic. Fetal risk, but the risks are considered appropriate to the need of the mother. If she needs her benzodiazepines to keep from being overly anxious, if she needs tetracycline because she has some kind of an infection, if she needs her anti-seizure medicines, if she suffers from epilepsy. Category X, teratogenic Accutane, which is a strong form of tetracycline, and vitamin A. Fetal risks are too great for the benefits, so you have to stay away from antibiotics. They usually just keep you away from most antibiotics, but especially tetracycline. The problem with marijuana is the same as the problem with any other drug smoked. Oh, I'm sorry, I went backwards. Any medication prescribed for a pregnant woman should be closely monitored. Use of nonsteroidal anti-inflammatory drugs can elevate the pregnant mother's blood pressure. Benzodiazepines can accumulate in the fetus's blood even at safe levels for the mother. Because of the fetus's smaller system, it will take longer for the infant to clear the drugs from his or her system, and they may be born addicted. Because of the slowness in clearing the infant's system, the baby will be born with withdrawals that may persist for weeks. And as I told you, my nephew, my great nephew, was born addicted and took him 6 weeks to detox the kid. And I've been in on detoxifications before. They're not a lot of fun, but of course I was just dealing with alcohol primarily. That wasn't easy. Medical people, we do so many strange things. At the turn of the 20th century, women rarely smoked. In 1920, only 5% of pregnant women smoked. Pregnant women smoking peaked in 1997 at 28.2%. In 2005, only 22.5% of pregnant women smoked during their pregnancy. 17% of women smoked cigarettes, 8.82% smoked right up to the time they gave birth. The highest rates were among African Americans at 20.12%. The second highest rate was among whites at 14.2%. Cigarettes are especially dangerous because of the nicotine and carbon monoxide found in the smoke, along with 2,000 other compounds. Both carbon monoxide and nicotine cross the placental barrier and reduce fetal oxygen supplies. Women who smoke or come in contact with secondhand smoke are in greater risk of premature delivery. Heavy smoking mothers are twice as likely to miscarry or have spontaneous abortions. Carbon monoxide has over 100 times a greater affinity for hemoglobin than does oxygen. Carbon monoxide is a single a molecule of oxygen, The oxygen that we breathe is O2. It's two molecules. And for that reason, carbon monoxide has a greater affinity for hemoglobin than does O2 because it's only carbon monoxide is only one molecule of oxygen. Babies born to heavy smokers average a birth weight 7 ounces less, with a smaller head circumference and about an inch shorter. With heavy smokers, there is a higher incidence of cleft palate, congenital heart defects, minor nerve and brain defects, higher incidence of SIDS, weaker sucking reflex, depressed immune system, and more respiratory infections. Caffeine is a common drug taken in by pregnant women in tea, coffee, and soda pop. In one study, 75% of babies born had caffeine in their system at birth. Infants tend to have lower tolerance for caffeine than adults do. Caffeine seems to have no long-lasting effects on the child, though physicians warn pregnant women away from its use during pregnancy. When my daughter was pregnant with my grandson, she was such a good girl, she stayed away from caffeine, which was not easy because she was kind of addicted to Pepsi. I think it was Diet Pepsi. She was into Diet Pepsi at the time. Anyway, she was good. She stayed away. Didn't drink any tea. Didn't drink any Pepsi. She was a good girl. Prevention of damage should start as soon as the woman discovers that she is pregnant. Physicians will ask the woman the 4 P's. Parents, did either of the woman's parents have a problem with drugs or alcohol? Partner, does the woman's partner have a problem with alcohol or drugs? Past, has the woman ever drunk beer, wine, or liquor? Pregnancy, in the month before the woman knew that she was pregnant, did she smoke cigarettes, take drugs, or drink beer, wine, or liquor? If necessary, the woman can be treated for her dependence. The most frequently abused drug, 46.5% among high school seniors. Tobacco, 21.6%. Marijuana, 18.3%. Smokeless tobacco, 6.1%. Painkillers, 3.8%. Amphetamines, 3.7%. Tranquilizers, 2.7%. Cocaine, 2.5%. Inhalants, 1.5%. Hallucinogens, 1.5%. MDMA, 1.3%. Steroids, 1.1%. Heroin, 0.4%. Any illicit drugs, 22.1%. In the last 30 years, tobacco and alcohol use has actually declined, while marijuana use has primarily stayed about the same. School environment has the greatest influence on drug and alcohol use. If the individual can reach the age of 21 without smoking and drinking, they probably never will. Of the people who experiment with alcohol or tobacco, more susceptible to peer pressure, 85.7% are still smoking in the 12th grade. If they have been drunk sometime in high school, 83.3% are still getting drunk. If they have ever tried marijuana, 76.4% are still toking. Adolescents who use marijuana weekly are 6 times likelier to cut class or skip school. One of the great oxymorons of adolescence is that while they think of their own thoughts as beyond question and their lives are invulnerable, they commit some of the most ill-advised acts that can sometimes lead to death. Intoxication in driving, intoxication in having sex. 70% of teen suicides involve alcohol. 50% of date rapes involve alcohol. 40% of drownings involve alcohol. Alcohol and drug use among adolescents has a great deal to do with crime. More than half the juvenile males arrested test positive for one or more illegal drugs. Marijuana is the most frequently found drug among these individuals. One of the major reasons people use psychoactive substances is to delay taking care of their problems. When this happens with an adolescent, they may not learn to deal with life's conflicts until they are deep into adulthood. They have prolonged the maturation process. Factors that lead an adolescent to use psychoactive substances. being subject to physical, sexual, or emotional abuse, being mentally or emotionally disturbed, lacking self-esteem, peer group encouragement to use drugs, inconsistent discipline where drug use is tolerated, dropping out of school, getting caught in the juvenile justice system, getting pregnant, living in poverty, lacking alternative activities, being in a school that does not control drug problems. Factors that help children avoid drugs: strong sense of family participation and involvement, family position on drugs, alcohol, and sex that the child can adopt as their own, strong spiritual sense and community involvement, attachment to a clean and sober adult role model. There are programs that have been developed to help school-aged children K through 12 stay away from drugs and alcohol. One is the DARE program, Drug Abuse Resistance Education. It's a 16 to 17 week session conducted by a uniformed police officer to 5th and 6th graders. The Dare to Be You program, The Family Matters, Lions Quest Skills for Adolescents. And strangely enough, I did Lions Quest research in Los Angeles when my wife was stationed at the RAND Corporation. She was stationed at RAND, and I worked for RAND as we did interviews for the Lions Quest Skills Adolescents program, and we traveled all over Los Angeles to the junior high schools, and we gave them surveys. Very fascinating work. Multisystemic therapy, MST, New Beginnings program, Project Towards No Drug Abuse, Seeking Safety, life skills training, increases social skills to help resist peer pressure. All the programs to help prevent drug abuse are similar. They all involve a coordinated effort among family members, teachers, and other school officials. These school-based programs tend to teach life skills, resistance education, and normative education. Normative education aims at correcting erroneous beliefs about the prevalence and acceptability of alcohol and drug use among an individual's peers. Family-focused primary prevention is a necessary adjunct to any school-based program. Experimentation, social use, habituation, and abuse usually begins in junior high school, 6th, 7th, and 8th grades. Because of this proclivity, primary prevention needs to continue, while secondary prevention is put in place to deal with those who didn't get the message. School personnel and families should be trained to recognize drug use and how to deal with the consequences. For those students who begin abusing drugs on a regular basis, treatment must be sought to reduce the probability of a lifetime of abuse. Such a program is positive behavioral interventions and supports, PBIS, adjustments to the environment to reduce the problem, building general competencies and teaching replacement skills, implementing consequences to promote positive behaviors and deter problems, crisis management or relapse plan. 1 in 4 children in the United States is exposed to alcohol abuse or dependence in their family. These children will be affected by alcohol even when they don't use. These children may play different roles in their family. Hero or model child tries to bring pride to the family. Problem child demands attention and is the most likely to use psychoactive substances. Lost child, shy and sidesteps problems by avoiding family and social activities. Mascot or family clown tries to ease tension in a dysfunctional family by being funny or cute, has a hard time growing up. Many alcoholic beverage companies target their advertising toward college freshmen, as establishing brand loyalty may generate as much as $20,000 to $50,000 revenue over the individual's lifetime. 49% of full-time college students binge drink and or abuse prescription and legal drugs. This is 2.5 times the amount of abuse found in the general population. Strangely enough, that at Wabash College, where I went to school, Rolling Rock beer was the popular beer when back in the 60s and 70s when I was there. So for our 50th reunion, guess what kind of beer they served? Rolling Rock. It was a little bit of a surprise. Of course, the people that were drinking the most of the beer were fraternity guys, and the college reunion 50th reunion, about a third of the people there were independents, and of course, we didn't drink any Rolling Rock beer. We didn't drink it, but the fraternities did. Of course, a lot of those guys had died of drug addiction. Some of them were alcoholics. Anyway, only about two-thirds. It was about 75% of the of our college were fraternity people, but only about two-thirds of the people at the 50th reunion were actually fraternity guys. Not the healthiest lifestyle in the world, I guess. The statistics on college students, and we're going to find out why in just a second. The statistics on college students has varying degrees of positive and negative. Daily smoking dropped from 15% in 1993 to 12% in 2005. Fraternity and sorority members are more likely to drink than non-members, 88% versus 67%. That's the statistic I was talking about. Non-members were independents at my school. Binge drinking, 64% to 37%. Driving drunk, 33% versus 21%. Using marijuana, of course, marijuana wasn't popular at all. You couldn't find it anywhere. I don't remember seeing it until I was in the military. But marijuana use, 21% versus 16%. Smoking, 26% versus 21%. And of course, these statistics are from not that long ago. And of course, I was in college, 54, 55 years ago. Only 6% of addicted college students seek help. 78% of college students who use illicit drugs have sex compared to 44% of those who never use drugs have sex. Psychoactive substances do have a heavy impact on our college campuses. 1,717 deaths in 2007 from alcohol-related injuries. 97,000 victims of alcohol-related rape or sexual assault. 696 assaults by another student who has been binge drinking. In 2002, the federal government legislated to deny college students federal aid if they had a drug conviction on their record. Of the 10,437,000 who applied, 41,000 were denied aid, while an equal number were waived who had completed a drug treatment program. Even the non-drinkers are affected by the drinkers. In a study of a campus where over 50% of the campus were binge drinkers, 87% of the non-drinking other students reported being victims of assault, being victims of unwanted sexual advances, having sleep interrupted, having study interrupted, suffering property damage, having to care for a drunken student, having to clean up after a drunken student, having impaired quality of life because of the drinking. And of course, we were on a college campus. We were independents, but it was an all-male campus. So the whole victims, well, the sexual advances part we can't really talk about. But of course, it didn't happen. But having sleep interrupted, certainly. Having study interrupted, oh, you bet. Suffering property damage, well, I didn't have anything for them to destroy. Having to care for a drunken student, oh yeah, that was not fun. Having to clean up after a drunken student, they're talking about vomit here. And it's liquid. Oh my God, and it stinks. Oh, what a smell. And having impaired quality of life because of the drinking. I was gone as many weekends as possible. Of course, I was dating at the time. I had a steady girlfriend who eventually became my wife. So it's one of the reasons why I wasn't there on the weekends. But the weekends I was there, it was miserable. Drinking and drug experimentation are seen by some as a rite of passage for college students. However, one approach to the control of college drinking is a normative approach where the myths of rampant drinking are debunked. For example, 68% of college students thought that their peers thought frequent intoxication was acceptable, while only 14% actually did. Within 18 months, within disseminating normative information, one college campus found 16% reduction of drinking to get drunk, 21% reduction in frequent heavy drinking, 31% reduction in missed classes, 36% reduction in property damage, and 40% reduction in unprotected sex. Means of controlling alcohol use: regulate campus drinking. 25% of campuses ban beer. 32% prohibit liquor on campus. 98% prohibit kegs in dorms. Provide alcohol, tobacco, and drug-free dorms. Wellness halls. About 2/3 of campuses offer such dormitories. Prohibit alcohol at campus events and fraternity sorority parties. Announce and enforce campus alcohol and drug policies. Work with the local community to make sure that alcohol is not served to minors. Strengthen academic requirements. Means of controlling alcohol use on college campuses: schedule more classes on Friday. Yeah, like that's going to happen. Keep the library and recreational facilities open longer. That's a good idea. Prevent alcohol promotions on campus, and this is alcohol promotions are this used to be very common on the larger campuses, larger state universities and whatnot. Notify parents when students run afoul of the drug and alcohol regulations. Provide server training for bartenders at college-sponsored functions. Ban alcoholic beverage advertising in the college newspaper. 50% of campuses ban such advertising. Integrate substance abuse education into the curriculum. Maintain a substance abuse officer to oversee on-campus use and abuse. Join a higher education prevention consortia. There are 90 such consortia on college campuses. Create programs to work with the neighborhood and community. Initiate early detection, intervention, enforcement, and referral. Studies show that a good drug education program will actually increase the level of experimentation but decrease the amount of abuse. Bad education will actually increase abuse. Studies show that as most college students mature, their alcohol and drug use becomes more sensible. People take psychoactive substances either to enhance some aspect of their sexual sensation or not realizing that it will interfere with their sexual sensations. Select psychoactive substances can replace normal sexual emotions, meaning that the emotions will seem to be there when they are not. Intimacy, comfort, love for one's children, release from anxiety. Love, sex, and drugs: a glass or two of wine to get in the mood. A cigarette after sex. A popper to intensify an erection or orgasm. Amphetamines to delay ejaculation. Marijuana to enhance the newness of the situation. Ecstasy to increase empathy. Drugs are desirable when the individual feels a physical, social, or emotional deficit. This has to do with aging, shyness, lack of confidence, diminished desire, diminished abilities. Unfortunately, the same drugs, when used long-term, may create the reverse effect: lack of sexual interest, physical depression, inability to achieve an erection, inability to achieve an orgasm. Drugs may trigger sexual aggression, sexual harassment, rape, child molestation, high-risk sexual behavior. The three main effects of a psychoactive drug on sexual behavior are desire, excitation, and orgasm. They do this by releasing hormones, affecting blood flow, affecting blood pressure, affecting nerve sensitivity, and affecting muscle tension. Some examples of psychoactive interference with normal sexual activity: heroin desensitizes penile and vaginal nerve endings. Alcohol diminishes spinal reflexes, decreasing sensitivity and erectile ability. Steroids increase testosterone, making the user more sexually aggressive. Cocaine and amphetamines release dopamine, which mirrors the release of dopamine during orgasm. Many drugs affect the hypothalamus, which can trigger unwanted hormonal changes. Chronic drug users combine sex and drugs to lower inhibitions, try to make themselves perform better, increase their fantasies, shield themselves from their sexuality, remove themselves from emotional involvement. Alcohol's effect on sexual function are directly related to blood alcohol levels. Women may use alcohol to lower their inhibitions, to increase sexual pleasure, to raise self-esteem and feelings of adequacy. However, with the increase of alcohol, there is actually less of a chance of orgasm. Women are more likely to drink to hide sexual dysfunction than men. Engaging in sex seems to be something to do while you're drunk. For men, enough alcohol can actually prevent them from being able to have an erection, as it diminishes spinal reflexes, decreasing sensitivity and erectile ability. Alcohol also lowers testosterone levels while increasing the female hormone estradiol. Chronic male drinkers will have a greater decreased testosterone and greatly increased estradiol, creating abnormalities in sex steroid metabolism. Men like alcohol because it anesthetizes the area of the brain that causes fight or flight and fear, making them more aggressive. However, it does lower testosterone, making men more likely to act asexual. In one study of heavy drinkers, 60% reported being impotent. Amphetamines and cocaine have always had the reputation of being sexual enhancers, but this is especially true in the gay community because it increases confidence, it prolongs erections, it increases endurance, and it intensifies orgasms. This is especially true of methamphetamine, which lasts longer in the individual's system. Amphetamines and cocaine can greatly intensify the pleasurable feelings that an individual gets from sex. Unfortunately, with continued use in sexual situations, the intensity lessens. As dysfunction begins, the individual will seek to use more and more of the drug to achieve normal sexual functioning. The drug will also intensify pre-existing sexual proclivities. If this is something as harmless as sexual inhibition, it will make the individual more confident. If the proclivity is pedophilia or rape, the drug can intensify these behaviors as well. While cocaine may work wonders for men when first used, with prolonged use, the effects may be unintended. Delayed ejaculation, decrease in sexual desire, difficulty achieving ejaculation. In women, cocaine may disrupt the menstrual cycle, cause difficulty in achieving orgasm, decrease desire. Smoking after sex has become a cliche for having had sex. In truth, long-term tobacco use is associated with a lower testosterone and erectile dysfunction. In women, it causes reduced fertility. The opioids are depressants and so may act to lower an individual's inhibitions when first used in concert with sex. However, with prolonged use, long-term users report impaired performance and a decrease in sexual drive. In one study, the degree of impotence among males was 39%, jumping to 53% when the individuals were actually using the drug. Some of the sedative hypnotics have been touted as sexual enhancers: benzodiazepines, barbiturates, quaaludes. The reality is that the individual has lowered inhibitions, which makes it more likely that they will be willing to perform sexually. With prolonged use, the individual begins to suffer from sexual dysfunction and apathy toward sexual stimulation. Select sedative hypnotics have been used as date rape drugs. Rohypnol causes amnesia and lowered inhibitions that makes an individual less likely to resist a sexual assault. GHB lowers inhibition and makes sex more pleasurable. Too much can lead to sleep or even coma. The drug also has amnestic effects, meaning that you won't remember it in the morning. Marijuana's effects have much to do with the attitude of the individual when smoking, much like LSD. In a pleasant social situation, like at a party or on a date, the drug will make people less inhibited and more relaxed, making it more likely that they will do things that they wouldn't normally do. Research looking at marijuana in a controlled setting found that the drug inhibited orgasm but not desire. The biggest problem with chronic marijuana use is that the user does not learn to have sexual relations without being stoned. MDMA and MDA give their user a warm feeling toward others and induces a heightened sensual awareness. However, this heightened sensual awareness does not enhance the ability to have an erection. As well, orgasms are more difficult to achieve. Sexual excitement is unlikely when high on the drugs. If this response is going to occur, it is usually as the person is coming off the drug. Neither PCP or LSD are considered sensual drugs. As an anesthetic, PCP has been used to deaden the pain in select sexual practices in both the gay and the heterosexual communities. LSD, and as a matter of fact, no psychedelics, are known as sexual enhancers. Nitrites are used in both the gay and straight communities as a vasodilator and a muscle relaxer. Users claim that nitrites prolong and enhance orgasmic sensations if used just prior to the orgasm. Like Viagra and other ED medications, nitrites act as vasodilators promoting penile erection. Nitrites also relax the anal sphincter muscles supporting anal intercourse. Psychotropic medications often will interfere with sexual functioning. Tricyclic antidepressants have been linked to decreased desire, problems with erection, and delayed orgasm. SSRIs also cause delayed or inhibited orgasm and impaired erection abilities. Antipsychotics inhibit erectile function and ejaculation as well as desire. With heavy doses of lithium, desire decreases, and individuals report having difficulty maintaining erections. Aphrodisiacs actually may not exist, though some drugs will enhance sexual situations. The erectile dysfunction medications Viagra, Cialis, and Levitra allow increased blood flow to the penis, but do nothing for sexual desire. Spanish fly irritates the bladder and the urethra, but does not actually increase desire. Human pheromones increase sexual desire and sexual stimulation, but only select pheromones work on select people. Yohimbine can enhance blood pressure and heart rate, increasing penile blood flow, but not desire. Drugs are often present in cases of sexual assault. 51% of victims reported using drugs or alcohol before the assault. 44% of the assailants used drugs or alcohol before the assault. Irrational or inappropriate desires may occur after alcohol lowers inhibitions and muddles rational thought. Stimulants make the user feel more confident and aggressive, making it more likely that a date will be assaulted. Sedatives lower inhibitions, making women more susceptible to assault. Marijuana makes users more suggestible to sexual activity. PCP and heroin make users less sensitive to pain, making it more likely that they will damage their partners during sex. Drug use peaked in the 1980s. Positive drug rates at work were 13.6% in 1988. By 2006, with actually more drug testing, the rate had dipped to 3.8%. The lower drug use levels at work may be due as much to drug users avoiding companies that drug test as drug usage at work declining. Estimates are that 8.2% of all workers use illegal drugs. 8.4% of full-time workers are heavy alcohol users. Contrary to the image of the addicts skulking around alleys to support their drug habits, 74.8% of addicts over 18 are employed as full-time or part-time employees. 80% of binge drinkers are employed. 62% of the people diagnosed with substance abuse disorder were employed. Unfortunately, substance abusing employees do not make good employees. They are late 3 to 14 times more often. They are absent 5 to 7 times more often. They make more mistakes than other employees. They tend to have a lower output. They are more likely to appear in a greater number of grievance hearings. They are 3 to 4 times more likely to have an accident on the job. They use 3 times more sick leave. They file for workers' compensation 5 times more frequently. They overutilize health insurance along with their families. They cause premiums to increase for medical insurance. They endanger the health and well-being of coworkers. The most common drug found in employees in samples: marijuana 48.8%, cocaine 16.4%, amphetamines 9.3%, opiates 6.7%, benzodiazepines 5.4%. 26% of people tested for cause tested positive. The area of the country that was the most likely to have positive drug tests was in the rural South. Employee assistance programs, EAPs, are programs established to help employees become better employees by providing treatment and counseling when needed. 45% of all employees in the United States are covered by EAPs. 70% of all employees working for organizations with more than 500 employees are covered by EAPs. EAPs do work. Northrop saw a 43% increase in production from the first 100 employees they sent to an alcohol treatment program. Employees of the Philadelphia Police Department who went through treatment reduced their sick days by 38% and their injury days by 62%. Providing EAPs for their employees at the Oldsmobile plant in Lansing reduced their lost work hours by 49%, healthcare claims by 29%, sick leaves by 56%, grievances by 78%, disciplinary problems by 63%, and accidents by 82%. Unfortunately, Oldsmobiles are no longer made, and that plant has closed in Lansing. There are several types of EAPs based on financial need. Internal in-house programs are found in large companies who can afford the expense. Fixed fee contracts, the company contracts at a set fee for any programs needed. Fee for service contracts, the company contracts with an outside EAP on an as-needed basis. Consortia, small employers get together to contract with an outside EAP service. Peer-based programs, peers and coworkers provide the needed services. The military has been at the forefront of the drug testing since the war in Vietnam, and this is one of the jobs that I had when I was in the military, starting in the early 1970s. In the late 1970s, drug testing in Europe peaked at 1 in 3 soldiers testing positive for illicit drugs. In 1980, 27.6% of soldiers in the military tested positive for illicit drugs. By 1998, the level of illicit drug use in the military had dropped to 2.7%. By 2005, the level had been cut by more than 100% to 1.11%. Intense drug testing can be credited for this success. And of course, that's one of the jobs I had. As I said, I was in the service from 1971 to 1983, and I was in Europe in 1980. I was one of the individuals that were finding these people. There weren't as many Air Force personnel, lots of Army guys, though. It was a mess. The military has maintained a reputation for heavy drinking since its inception. It wasn't until after Vietnam and the drug control movement that the military began concentrating on curbing instead of promoting alcohol use. Little story, when I became a sergeant in 1973, 73. Became a sergeant in 1973, and as a sergeant, I had to join the NCO club. That's where you drank. And every time you went into the NCO club, you had to buy 2 drinks. That was the rule. And I refused to join, and I refused to buy drinks. So the base commander started having mandatory uh, mandatory meetings there, and I wasn't supposed to go in because I wasn't a member. And if I did go in, I was supposed to buy 2 drinks. Well, anyway, it got ugly. Um, Eventually, they they cut all that out. Anyway, strange stuff. Highest rate of alcohol abuse in the military is shock, in the Marine Corps branch. The lowest level of alcohol abuse is in the Air Force. Hey, that's where I was, with the other 3 branches of the military, the Army, the Navy, and the Coast Guard, somewhere in the middle. So the Air Force is the not the best drinkers, are the worst drinkers, and the Marines are the best drinkers. The Air Force was the first branch of the service to crack down on drug and alcohol abuse, and they have been at the forefront of drug and alcohol abuse among the services. The first military EAP was the Air Force's Alcohol and Drug Abuse Prevention and Treatment Program, ADAPT. The Army soon followed with Army Substance Abuse Program, ASAP, and the Navy's Navy Alcohol and Drug Abuse Prevention Program, NADAP. The military's programs have been so successful because the military has almost absolute power over all military personnel. In other words, if somebody gives you a direct order, you have to do it. You don't have a choice. They can conduct urinalysis testing whenever or wherever they choose. If a military member refuses to comply, either drug testing or drug rehabilitation, the military can charge them with disobeying a direct order and can discharge them from the service for disobeying a direct order. So they have to collect the urine specimen. And if they have been ordered to go to drug treatment, they have to go. Or lose their stripes, go away, kick them out. And that's one of the reasons the Air Force did this back in the 70s. And that's one of the reasons why the Air Force has always had a lower alcohol problem than the other services. They started it. With the influx of reservists and National Guard members into active duty with the hostilities in Afghanistan and Iraq, the Department of Defense instituted the following drug policies: 100% random testing of all active duty personnel, conduct random drug testing on all military personnel within 72 hours of entering active service, separate positive testing personnel from the military, zero tolerance, test the mandatory test panel to include new drugs, maintain 100% mandatory testing for DoD civilian personnel. There's a reason why drug testing has shown a 66% drop in positives from 1988 to 2004. Self-reported positives have increased by 30%. Drug users will avoid applying for jobs at businesses that require a drug test. There are ways to beat the drug test, though most of them depend on a non-observant specimen collector. And I collected specimens with thousands of guys. And by golly, damn it, I saw them all. I figured out how to maintain 100% culpability. I even had people come up to me and ask me or try to bribe me. Didn't work. I didn't need money that bad. Reasons for drug testing include pre-employment testing, for cause testing, random testing, post-accident testing, periodic testing, rehabilitation testing of criminals on probation, testing for compliance of addicts and treatment, testing by medical examiners to determine cause of death. 12 states allow for testing of welfare recipients. The most widespread testing is in the military, federal government employees, pre-employment drug testing in public safety positions such as transportation, drug treatment facilities. Drug testing can be conducted on any substance from the body, urine, blood, hair, saliva, sweat, tissue, if necessary. Usually the tissue is from a cadaver, but usually it's just urine is the easiest thing to collect. In Germany, it's blood. And I'll tell you what, it wasn't lab techs that drew the blood, it was the cops. And the Polizei are not the best phlebotomists in the world, I can tell you. Wow. I saw some pretty ugly bruises from guys that had been drawn, had their blood drawn from by the police. And the police, of course, they're not known for being gentle, especially Polizei, the German police. And I don't think they meant to be gentle. Standard drug testing tests for amphetamines, cannabinoids, cocaine, opioids, phencyclidine, PCP, and alcohol. Other drugs that can be added to the testing: barbiturates, benzodiazepines, methadone, propoxyphene, which is Darvon, and methaqualone. We tested all of these except cannabinoids. We couldn't test for marijuana. And we didn't test for PCP. It wasn't very popular. But we tested for cocaine, amphetamines, and opioids, and alcohol. Drugs that are normally not tested for but can be added if suspected: LSD, fentanyl, psilocybin, MDA, and the designer drugs. These are magic mushrooms. Methods of testing include thin layer chromatography, TLC. This method tests for a wide variety of chemicals and is very sensitive to minute amounts of any chemical. The problem is that it can't differentiate between chemicals with similar structures, for example, ephedrine and amphetamines. Enzyme multiplied immunoassay techniques, IMIT, radioimmunoassay, RIA, and enzyme immunoassay, EIA. IMIT tests use antibodies to seek out specific drugs. It is very sensitive and rapid, but it cannot determine concentration and produces several false positives, such as poppy seeds, which will test positive for heroin, ibuprofen, which will test positive for marijuana, and Vicks Vapo inhaler, which tests as crank. We used immunoassay, a radioimmunoassay, and an enzyme immunoassay. Methods of drug testing, and then if anything was positive, we did a gas chromatography. Gas chromatography, mass spectrometry combined in gas liquid chromatography. Ours was gas chromatography. We weren't that sophisticated. This system is the most sensitive, accurate, and reliable method of drug testing. This system is so accurate because the technique actually breaks each chemical into fragments and then reads the fragments. This method eliminates false positives and false negatives because it not only identifies the chemical structure of the drug, but it cross-references it with the metabolites that it produces. This drug is very expensive. This test is very expensive and requires highly trained operators. And of course, we did all this at Brooks Air Force Base down in San Antonio. I came in 71, and I graduated from lab school in December. No, in March of 72. So out of my class, 2/3 of them went down to Brooks to do drug testing, to be the people that did the drug testing, and only 1/3 of us went into the laboratory. Luckily, I went into the laboratory because I enjoyed medicine more than trying to find people who. But I collected drug urines. That's what I was talking about. And this is the type of stuff that we use. Hair analysis can be done as most chemicals taken into the body are represented in the keratin of the hair follicle. Hair analysis tells the tester what drugs have been used while that specific hair follicle has been alive. Radioimmunoassay tests are run on the hair follicle. Confirmation is done with gas chromatography and mass spectrometry. Drugs can be detected on saliva, sweat, and on the breath. These tests are easier to obtain as they are less invasive, but they also only serve as screening tests and are prone to contamination. The alcohol breathalyzer is a good example of a breath test. Follow-up tests should always be done to confirm any results. So with a positive test in some states, they will take you to the hospital to have your blood drawn. There are many factors that influence the length of time a drug will remain detectable in a person's system. What drug it is, absorption rates, metabolism, rate of distribution in the body, excretion rates, the method employed for testing. Detection rates of psychoactive drugs: alcohol is detectable 3 to 5 days, amphetamines 2 to 4 days, methamphetamines 2 to 4 days, barbiturates only 24 hours, clonazepam about 40 to 80 hours, and diazepam, long-acting diazepam, that's Valium, 7 to 30 days. Cocaine, crack cocaine, 6 to 8 hours. Meth, 2 to 3 days. Marijuana, single use, 1 to 3 days. 4 joints a week, 4 to 7 days. Daily use, 10 to 15 days. Chronic heavy use will stay in your system for 1 to 2 months. It's in your fat. Nicotine stays in your system for about 12 hours. Opioids, buprenorphine, 48 to 56 hours. The buprenorphine conjugates, 5 to 7 days. Codeine, 1 to 2 days. Heroin, morphine is measured 2 to 4 days. Hydromorphone, dilaudid is measured, that's dilaudid, 2 to 4 days. Methadone, limited use, 2 to 3 days. Methadone maintenance use, 7 to 9 days. Morphine, 2 to 4 days. Oxycodone, which is another name is OxyContin, 2 to 4 days. Propoxyphene or Darvon, 6 to 48 hours. PCP, casual use, 2 to 8 days. Chronic use of PCP, and I don't know why the hell you do that, but it's several months. LSD and its metabolites, 2 to 4 days. Ecstasy, 30 to 48 hours. Drug testing does seem to be reliably accurate, but it is not infallible. False positives can happen when dextromethorphan has been misidentified as opiates. Some herbal teas have been known to test cocaine positive. Poppy seeds from baked goods have been misidentified as opiates. Errors have also been found after testing personnel mishandled specimens. However, most laboratory errors are false negatives than any other error. Specimen can be manipulated by the testee to create a negative test when the testee is actually positive. Clean urine can be introduced into the specimen by concealed containers. Urine injected into your bladder, somebody else's urine, clean urine, into your bladder. You can use catheterization. Substances that have been introduced into the urine to mask the drugs present with more than questionable results include aspirin, golden seal tea, niacin, zinc sulfate, bleach, clear, water, ammonia, Drano, hydrogen peroxide, lemon juice, liquid soap, vinegar, and Visine. Of the people over 65, 83% take at least one prescription drug per day. 30% take 8 drugs or more per day. 17% of people over 60 in the United States abuse alcohol and legal drugs. Unfortunately, our society doesn't pursue elder drug abuse and alcoholism as fervently as they do these problems in younger individuals. Only 30% of elderly alcoholics are identified as compared to 60% of younger abusers. Drugs do not work the same in the system of an elderly individual as they do with someone who is younger. Enzymes in the elderly tend to be less active than in younger people. This tends to make drugs more potent in older people. For example, the loss of liver enzymes means that an individual 70 years old will get the same effect from 10 milligrams of Valium as a 21-year-old taking a 30 milligram dosage. The most frequently abused drugs after alcohol for the elderly are hydrocodone, Vicodin, narcotic cough syrup, Darvon and other opioid analgesics, prescription sedatives such as Klonopin, over-the-counter sedatives, over-the-counter sleep aids, Prozac, Zoloft, and Buspar. While not everyone takes their medications in the prescribed manner, the elderly tend to have more problems than others, probably memory problems. Overuse, taking more or many different types of drugs than prescribed. Underuse, failing to take appropriately prescribed drugs or the correct dosage. Erratic use, failure to take drugs in the right dosage or at the right time. Contraindicated use, incorrect drug use being used, causing an adverse reaction or drug inactivity. Abuse and addiction, using drugs for non-medical purposes despite negative consequences. Common drugs abused by the elders: nicotine, 94% of all 430,000 premature deaths from smoking are in people over 50. Tobacco's effects are actually more pronounced in elderly because of their inability to clear toxins as they did when they were younger. Elderly smokers have twice the mortality risk of cardiovascular disease than non-smoking elders. Caffeine, the average consumption of caffeine for the elderly is 200 milligrams, 2 cups of brewed coffee. Caffeine toxicity can be seen at doses as low as 100 milligrams. When seniors use excessive caffeine, it can lead to loss of bone density, increasing the possibility of hip fractures. The most prevalent problem among elderly is alcohol. 6 to 11% of elderly hospital admittance show signs of alcoholism. ER visits find up 14% of the elderly show signs of alcoholism. 20% of the elderly in psychiatric wards are alcoholic. 49% of the elderly in nursing homes are alcoholic. Because of the presenting medical problems, alcoholism is often overlooked by medical personnel. Alcohol affects the elderly so much more seriously than a younger individual because they have a less efficient liver, they have a decrease in body water, they have an increase in sensitivity to alcohol, they have a decreased tolerance to alcohol, a decrease in metabolism of alcohol in the gastrointestinal tract. So it's not just the liver, it's also the gastrointestinal tract. Lower amounts of alcohol will lead to intoxication for the elderly. They're a cheap drunk. Over-the-counter medications can cause the elderly problems. Sedatives contain antihistamines for their sedating effect, and the liquid forms have more alcohol than wine. Unisom, Sleep Ease, Nitol, and Sominex. Cold medications will contain the same combination of alcohol and antihistamines. Abuse of prescription drugs has been reported as low as 5% and as high as 33%. This occurs even in extended care facilities. Benzodiazepines are used by 71% of elderly between 50 and 65, and 33% by those over 65. These drugs can cause confusion and falls. Abuse of prescription opioids and analgesics have increased by 500% since 1990. OxyContin, hydrocodone, also known as Vicodin, Lortab, and Norco. While few think of the elderly as drug abusers, of the total hospital admissions for the elderly, 20% are directly due to prescription or over-the-counter drug reactions, exclusive of alcohol and illicit drug admissions. 20% of the elderly were regular drinkers and continue to exceed controllable amounts. 5 to 12% of men and 1 to 2% of women. 80% of senior arrests are for drunkenness. Primary prevention for the elderly need to be educated as to the changing effects of alcohol and drugs as they get older and the increased dangers of excessive use. Secondary prevention with this age group involves recognizing the early stages of alcohol and drug addiction and appropriate intervention tactics. Tertiary prevention, treatment for the elderly involves a slower pace of therapy, focusing on patience and reassurance. And that is the end of the lecture. So I'll talk to you guys probably not maybe next week. I don't know. We'll see.